Hello everybody, this is Chris with the Ancient Scholar. So today I'm going to be doing another literature review. I know I just did one, but this is actually pretty important, and it could change the way that we potentially practice respiratory therapy. So I wanted to go ahead and get it out. So I have access to the abstract. It's not the entire article, but it is high points, and this comes from the Annals of Internal Medicine. It's a clinical guideline change, the American College of Physicians Guidelines of Clinical Practice. The name of the article is Diagnosis and Management of Stable Chronic Obstructive Pulmonary Disease, a Clinical Practice Guideline Update from the American College of Physicians, American College of Chest Physicians, and American Thoracic Society. American and European Respiratory Society is authored by Dr. Amir Kazim and company. So let's go. I'm going to go ahead and just look at the abstract here. It's an official statement. American College of Physicians, American College of Chest Physicians, etc., etc. The methods that they used guidelines based on targeted literature update from March 2007 to December 2009, evaluating the evidence and then updating their recommendations based on this literature evaluation. Okay, so the first recommendation that came from us, and again, I'm giving you guys a Reader's Digest version of this. This is not the entire article, it's just the abstract. But the first recommendation is that they recommend baseline spirometry to diagnose airflow obstruction on patients with respiratory symptomology. This is a strong recommendation, very good evidence to do this. So somebody has respiratory symptomology, they should have a spirometry done and then be managed based on their spirometry. Sometimes, you know, you'll look at the physician will look at a patient, they won't necessarily do spirometry, and then they'll just start managing them. They'll say, okay, well, sounds like you have asthma to me, I'm going to go ahead and put you on albuterol. And now that they're strongly recommending, there's really good evidence that, hey, you know what, maybe if somebody has respiratory symptomology, we need to do baseline spirometry on them. This is, again, strong recommendation of moderate quality evidence. Spirometry should not be used to screen for airflow obstruction in individuals without respiratory symptoms. So basically what this says is, look, if your patient is asymptomatic, you don't need to do anything. And there's actually a strong recommendation for that as well with moderate quality evidence. Okay, recommendation 2. For stable patients, patients have COPD, they're stable, and they have FEV1s of 60-80% are predicted. They suggest that treatment of inhaled bronchodilators may be used. Okay, so 60-80% is actually pretty good, because 80% and above is generally considered normal for predicted FEV1s. So these are very stable patients. Weak recommendation, low quality evidence for managing these patients on bronchodilators. Okay, recommendation 3. Okay, patients with respiratory symptoms and FEV1 of less than 60% of predicted, it is recommended that we use inhaled bronchodilators to treat these patients. Strong recommendations, moderate quality evidence there. Okay, recommendation 4 recommends that clinicians prescribe monotherapy using either long-acting inhaled anticholinergic agents or long-acting beta agonist for symptomatic patients with COPD and FEV1 values of less than 60% predicted. Strong recommendation with moderate quality evidence. Clinicians should base the specific monotherapy on patient preference, cost, and the adverse effect profile. Now, we know that long-acting bronchodilators, specifically your beta, your long-acting betas, some of those medications are associated with some very serious consequences, or sequelae, of using them and not using them correctly. So we need to be very careful about using long-acting beta agonists. But I think the take-home point is, if somebody has stable COPD, their FEV1 is, or symptomatic patients with COPD, excuse me, but then they have an FEV1 of less than 60%, they do recommend, look, you know, we should be looking at some sort of long-acting agent, either an anticholinergic or a beta agonist, and see how they do with this long-acting agent, and base the decision of agent on obviously the patient, cost, and ultimately the side effect profile. Okay, recommendation 5 suggests that clinicians may administer combination therapies, i.e. long-acting anticholinergics mixed with long-acting beta agonists, or the flavor of the month, if you will, long-acting beta agonists and steroids. Really big thing. For symptomatic patients with stable COPD and FEV1 of less than 60%. Interestingly enough, the evidence is a weak recommendation with moderate quality evidence. So what they're doing is they're saying, hey, you know, there's actually a stronger recommendation for starting out on monotherapy agents. So, you know, we're very familiar with these combined agents. In fact, I was on a combined agent at one point, Bronchodilator on long-acting beta agonist, but really the recommendation for trying to go with a mono agent therapy seems to be much stronger than the recommendation to go with multi-agent therapy. And I think intuitively that does make sense, because, you know, the more polypharmacy that you run into, obviously the side effects profile, or the potential side effects profile, is going to be potentially a lot larger. All right, recommendation 6, clinicians should prescribe pulmonary rehab for symptomatic patients with an FEV1 of less than 50% predicted. Strong recommendation with moderate quality evidence there. Clinicians may consider pulmonary rehab for symptomatic exercise-limited patients with an FEV1 of less than 50% predicted. That's a weak recommendation, moderate quality evidence. Or greater than 50% predicted, excuse me. So basically what they're saying here is there's a strong recommendation for pulmonary rehab if my FEV1 is low, less than 50%. And I think intuitively that makes sense. If we have low FEV1s, we can do some pulmonary rehab in attempt to optimize whatever that patient may have. And obviously, intuitively, I'm not saying the evidence is saying this, but intuitively I think that pulmonary rehab is also a good point of contact for patient education. We can catch some of these patients and see how compliant they are with their therapies and medications and smoking cessation, and it's just another point of contact, or another chink in the healthcare chain. You know, we can interface with these patients and perhaps educate them and help them become more compliant with their therapies. So that may be a component. Obviously, the evidence here doesn't say that. That's just me, my assumptions, my suppositions. Okay, and then recommendation 7 recommends that clinicians should prescribe continuous oxygen therapy in patients with COPD who have severe resting hypoxemia, and this is described as a PA, little a, arterial tension of less than 55 millimeters of mercury, or SpO2 less than or equal to 88%. Again, severe resting hypoxemia, strong recommendation, moderate quality evidence there. Okay, guys, that is the summary. Again, not really huge change. I do think that it is nice to have some guidance about mono and multi-medication therapy, however, for managing COPD patients. And again, this is for managing stable COPD patients. These recommendations, I want to emphasize that this is not managing a patient who is having an acute exacerbation. This is after they're stabilized, and we're looking at long-term management. Okay, guys, I'm going to cut off here. Thanks for hanging in there.